Hello, friends. I am Dr. Manoj Kumar Goyal. I am Principal Director, Pulmonology, Critical Care and Sleep Medicine at Fortis Hospital, Gurgaon. And today I'll be talking about the management of high-risk pulmonary embolism, particularly describing thrombolysis versus thrombectomy. So let me share my slide deck. So pulmonary embolism is a life-threatening condition, especially if it has massive or what we nowadays call as high-risk pulmonary embolism. And the management of high-risk pulmonary embolism is done either by thrombolysis or thrombectomy. The idea is to restore the perfusion of the pulmonary arteries as quickly as possible by either dissolve the clot or by removing that clot by surgical method, or sometimes by catheter-directed, thrombectomy from the pulmonary artery. So next 20 minutes or so, I'll be discussing high-risk pulmonary embolism and also a little bit of intermediate high-risk pulmonary embolism, where there could be a role of thrombolysis. So if you look at this slide, it shows that shock is a very important parameter in the management of pulmonary embolism. So patients of pulmonary embolism present with shock would have a mortality as high as 40% as compared to people who present without shock, where the mortality could be 11%. So shock state really magnifies the risk of mortality by 400% as a matter of fact. And therefore, management of high-risk pulmonary embolism is a very, very important issue. So what are the indicators of risk stratification in pulmonary embolism? Number one is the hemodynamic stability. Pulmonary embolism severity index, what we call as a PESI index. It's a clinical bedside index, which we must do, and it's very important, especially in case of high-risk pulmonary embolism. Third thing is the assessment of the RV function, especially RV dysfunction, either by doing transthoracic echography or on the basis of CT pulmonary angiography, and elevated cardiac enzymes, especially troponin levels. So all these four indicators are used for risk assessment of pulmonary embolism. Accordingly, the pulmonary embolism is classified into its risk severity, into high risk, intermediate risk, and low risk. And intermediate risk further classified into intermediate high risk, intermediate low risk. And these are the clinical indicators of risk stratification. And what you see in the red line is somebody presented with hemodynamic instability, straight away classified as high risk pulmonary embolism. These patients are at very high risk of mortality. That's why they're classified as high risk. People with PESI class 3 or 5 are then classified as intermediate group if they are not having any hemodynamic instability, and they're further classified into intermediate high and into low, depending upon the RV dysfunction and elevated cardiac troponin levels. So the high-risk pulmonary embolism is defined as a pulmonary embolism with presence of hemodynamic instability, that is in shock. Now, these are the two cases which I illustrated here. Both of them got extensive pulmonary embolism, where you can see the embolus is there in the main right main pulmonary artery, is also left main pulmonary artery in both these two patients. Now, one of these cases actually may be a case of high risk or may not be. So let's see what happens. So the case one has a normal blood pressure, his hemodynamic is stable, his ECG, RV function, BNP, troponin, all is acceptable level. Whereas case two has got hemodynamic instability with shock state of BP of 80-50, tachycardia, tachypnea, SpO2 82% room air. So clearly patient number two is a high-risk patient, and he is a candidate for thrombolysis. Whereas case one or patient number one is not a high-risk group because he's hemodynamically stable, and this patient can be treated with anticoagulants. So even though on CT scan the extent of the embolism may be similar, but the management of these two cases would differ depending on the hemodynamic stability. And generally what we do, we see a case like this on the CT scan, we think that he's got high-risk pulmonary embolism, rush for thrombolysis in this patient. But before doing that, you must look at his clinical parameters, biochemical parameters, and also echocardiography to decide the modality of treatment. For high-risk pulmonary embolism, the International Cooperative Pulmonary Embolism Registry, as ICOPR, found that 90-day mortality rate for patients with high-risk pulmonary embolism with shock was 52.4%, compared with 14.7% those without shock. The shock state is a very important determinant of the mortality risk. And if the patient is shocked, the mortality rate is very, very high. And therefore, international guidelines suggest thrombolitic therapy for the treatment of high-risk pulmonary embolism because you want to achieve the reperfusion as early as possible. The intermediate high-risk pulmonary embolism is defined as patient with presence of PACE class 3 or 5 or simplified PACE score equal to more than 1, RV dysfunction with elevated troponin I in absence of hemodynamic stability. But some of these patients may be at a higher risk of mortality, and we'll try to understand those cases. These are pulmonary embolism severity index, which I was talking about. You don't have to remember all these parameters. These are all clinical parameters, bedside parameters, which you can score. And these apps are available on your mobile phone, so it's very easy to calculate this score. And if the score is 86 to 105, it is classified class 3. Score of 106 to 125 is classified class 4. And similarly, more than 125 is class 5. So class 3 to class 5 is high risk group. Here the mortality risk could be as high as 24%. Now, for intermediate high risk pulmonary embolism, most cases would be without hemodynamic compromise. And in those cases, parenteral or oral anticoagulation without reperfusion technique is adequate treatment. So preferred treatment for intermediate high-risk pulmonary embolism remains anticoagulation. The largest double-blind controlled trial in submassive, that is high-risk, intermediate high-risk pulmonary embolism, that was a PITHO trial published in 2014, showed no mortality benefit thrombolysis, although mortality was low in both the groups where thrombolysis was done or those managed with anticoagulants. However, in the thrombolysis group, where the tenecteplase was used, showed a 10-fold decrease in incidence of intracranial hemorrhage, 2% versus 0.2%, and 5-fold increase in incidence of extracranial hemorrhage, 6.3% versus 1.2% as compared to anticoagulants. So clearly, thrombolysis group had a very high risk of complications as compared to the anticoagulant group without any additional mortality benefit in intermediate high-risk pulmonary embolism. Therefore, routine systemic thrombolysis is not recommended as the risk of potentially life-threatening bleeding complications appears to be too high for the expected benefits from the thrombolysis in these group of patients. So when to use systemic thrombolysis in intermediate high-risk pulmonary embolism patient, this is a complex clinical dilemma where a careful weighing of the risk-benefit ratio is needed from case-to-case basis. Now, certain cases with moderate to severe RV dysfunction, moderate to severe tachycardia, tachypnea and hypoxemia, borderline hypertension, extensive embolic burden, or residual deep vein thrombosis, cardiovascular comorbidities may be the candidates for thrombolysis, even though they may be hemodynamic stable. And if you got multiple of these risk factors are there, then the thrombolysis may be considered even in intermediate high-risk pulmonary embolism cases. There are certain other criteria where thrombolysis may be considered. If the RV-LV ratio is more than 0.9 or more than 1, TAPSE reduction is seen visually or is less than 18 millimeter. Bradycardia especially is there, which is quite worrisome, and these patients are at high risk. So patients of pulmonary embolism, bradycardia at higher risk of mortality as compared to patients with tachycardia. Similarly, shock index is there where the heart rate to systolic blood pressure more than 1 suggests poor hemodynamic reserve, and these patients may also have worse prognosis. So these patients may also be considered for thrombolysis. Another important parameter is the lactate level, where high lactate levels are also associated with high risk of mortality. So especially if the lactate is more than 2 or more than 3, you can see the risk of mortality rises exponentially. And these patients may also be considered for thrombolysis if they have intermediate high risk pulmonary embolism, even though they are hemodynamically stable. So therefore, each case should be considered on an individual basis, where risk and benefit of thrombolysis should be considered and weighed in the interest of the patient. The PITHO study also found that in patients over the age of 75, the bleeding risk was higher. So this must be considered in the risk-benefit ratio. So age is a very important factor. More than 75, the risk of bleeding is high. And therefore, this factor is also to be into consideration before deciding thrombolysis in this group of patients. But the current default position is to give therapeutic dose of low-watt heparin in intermediate high-risk pulmonary embolism cases. The administration of LMWH should not be delayed with the decision about thrombolysis is made. So when you're trying to decide whether to thrombolize these patients or not, please do not delay the administration of low-watt heparin. That is a very important step. It has to be given straight away. Rescue thrombolytic therapy or alternative surgical embolectomy or percutaneous catheter directed treatment should be reserved for patients who develop signs of hemodynamic stability. So we started anticoagulant therapy in intermittent high-risk group patients, and they become hemodynamic stable over a period of time. Then immediately you should, start thrombolysis in these patients. And the idea is to achieve the reperfusion in the pulmonary arteries. Now, the reperfusion treatment can be by systemic thrombolysis, where you give a thrombolytic agent through the IV route, and which is possible in practically all the intensive care units. The surgical embolectomy, which is done by CTVS surgeon, it is a very specialized surgery and not available in majority of the centers in the country. Similarly, percutaneous catheter-directed treatment may also be employed. It's done either by the vascular surgeon or interventional radiologist. Again, this kind of facility is not also widely available. But systemic thrombolysis is something that can be done in any of the intensive care units, and therefore I'll be discussing it a little bit in more detail. So coming to systemic thrombolysis, why do we need a thrombolysis? Because increased clot burden leads to blockage of the pulmonary circulation, which causes increased pulmonary vascular resistance and RV overload. It also causes RV dilatation, hypokinesia, and interventricular septal deviation. The interventricular septum deviates into the left ventricle, or so right ventricle actually bulges. There's abnormal LV filling because of that. And there's a decreased LV cardiac output and systemic arterial hypertension, RV ischemia, infarction, failure. And therefore, restoration of pulmonary circulation becomes very important. That can be achieved only by dissolving clot, which can be achieved by thrombolysis. Thrombolysis leads to faster improvement in pulmonary obstruction, pulmonary artery pressure, and pulmonary vascular resistance compared with the unfractured heparin alone. And these improvements are accompanied by reduction in RV dilatation. This study was published in American Journal of Medicine, which showed that the mortality was 47% when no thrombolysis was done, whereas the mortality was 15% when thrombolytic therapy was given. This in case of unstable pulmonary embolism, that is high-risk pulmonary embolism. And you can see it's on a large number of cases, 50,000 cases, the no thrombolytic therapy, around 20,000 cases thrombolytic. So it's very large patient data, which clearly shows that thrombolysis is the treatment of choice in patients with high-risk pulmonary embolism. Now, when to thrombolyze? The greatest benefit is observed when thrombolysis is initiated within 48 hours of symptom onset, but can still be useful in patients who have had symptoms for 6 to 14 days. So delayed thrombolysis can also be given if the patient develops hemodynamic instability at any point of time and patient is on anticoagulant. The unsuccessful thrombolysis is judged by persistent clinical instability and unchanged RV dysfunction on echocardiography after 36 hours, and has been reported in close to 10% of high-risk pulmonary embolism patients. So 1 in 10 patients may not respond to thrombolysis therapy, where the other options like surgical thrombolectomy or catheter-directed thrombectomy may be considered. One should also be mindful of the contraindication of thrombolysis. The absolute contraindication of thrombolysis include history of hemorrhagic shock or stroke of unknown origin, ischemic stroke in previous 6 months, CNS neoplasm which have a tendency to bleed, major trauma, surgery, or head injury in the previous 3 weeks, bleeding, and active bleeding. So the absolute contraindication. Here you would not go for thrombolysis, but go for other options of reperfusion therapy. The relative contraindications would include TIA in previous 6 months, patient already on oral anticoagulant, particularly VK, pregnancy or first postpartum week, non-compressible puncture size, traumatic resuscitation, refractory hypertension, systolic blood pressure more than 180, advanced liver disease, infected endocarditis, and active peptic ulcer disease. So these are relative contraindications where you may defer thrombolysis and offer other options. The thrombolytic regimens include the RTPA, which is most commonly used nowadays. The others are streptokinase and urokinase. Those of RTPA is 100 mg over 2 hours, but initially you give an infusion of 0.6 mg per kg over 15 minutes, and then you would give the rest of the dose, and the maximum dose in the initial first 15 minutes is up to 50 mg. The streptokinase, the other one which is commonly used, it is less expensive as compared to RTPA, but is not nowadays preferred, and urokinase is not currently available. So we have got the experience with RTPA and streptokinase. So currently the accelerated IV administration, that is rapid administration of recombinant tissue, rapid tissue type plasminogen activator, the RTPA, is preferred to prolong diffusion of first generation thrombolytic agents like this streptokinase, urokinase. So STK has to be infused over 24 hours, which is the traditional one, but accelerated IV administration of the RTPA is the current modality of choice. Now, why we prefer RTPA? Because RTPA causes significant improvement in the pulmonary vascular resistance rapidly, right, and more sustained as compared to streptokinase and heparin. Similarly, the RV ejection fraction improves significantly and faster with RTPA as compared to streptokinase heparin. Therefore, RTPA remains the choice for thrombolysis over streptokinase in the current era. But one has to understand that thrombolysis is not without risk. The major intracranial bleed has been observed around 3% of patients, and major bleeding has been observed around 21.7%. Around 20%, major risk of bleeding is there if you do thrombolysis. So that's why not every case is a candidate for thrombolytic therapy, then they have to be carefully selected. Now coming to surgical embolectomy. Now this is the case who presented to us with a saddle-like clot in the right main pulmonary artery, also left main pulmonary artery. And this patient also had subarachnoid hemorrhage. He had a history of hemorrhagic stroke 2 months back, and patient was bedridden at home and his general condition was weak. He also had acute kidney injury. That's why the MR angiography was done rather than CT pulmonary angiography in this patient. So clearly this case was not a candidate for systemic thrombolysis, and this patient underwent surgical embolectomy. And this is done by the CTV surgeon. And we have got that the CTV surgeon with us, Dr. Udgit Dhir. And you can see clots were removed and life of the patient could be saved. Coming to comparison of surgical embolectomy versus thrombolysis, a study compared between patients who underwent thrombolysis and embolectomy with 1854 cases in the thrombolysis group, the systemic thrombolysis group, and around 250 patients in the surgical embolectomy group as first-line therapy. And they found no difference between the two types of reperfusion treatment regarding 30-day mortality. It was similar, around 15%, but thrombolysis was associated with a higher risk of a stroke and reintervention at 30 days. Similarly, there was no difference found in terms of 5-year actuarial survival in these two groups, but thrombolytic therapy was associated with higher rate of recurrent pulmonary embolism, requiring readmission compared with surgery. So what are the indications of surgical embolectomy? High-risk pulmonary embolism in a patient with absolute contraindication thrombolysis where systemic thrombolysis cannot be given. High-risk pulmonary embolism with thrombolytic failure where thrombolysis therapy has failed over 36 hours. And this is observed in around 10% of the patients. And clot in transit, especially if the patient has got a pit in foramen ovale and the clot is lying across the PFO, then this is a grave situation because, during thrombolysis, if you give a systemic thrombolysis to this patient, this clot may get dislodged and cause severe stroke. Therefore, in this situation, you must go for the surgical embolectomy rather than the systemic thrombolysis. Coming to catheter-directed treatment, I'll show you one case. This is 85-year-old female with severe COPD, coronary artery disease, poor LV ejection fraction. She presented with acute and chronic pulmonary embolism. And as you can see, this is right and left pulmonary artery filled with filling defects. And this pain catheter-directed pulmonary thrombolectomy was performed by our vascular and endovascular surgeon. And this is the pulmonary angiogram. Where you can see there's multiple filling defects of number of clots in the pulmonary circulation where the catheter thrombectomy. So this is a rotating catheter which fragments the clot and then they are sucked out. So this is how it is, This is a catheter which is doing the thrombectomy. This is another way of, causing a thrombectomy, which we call a suction thrombectomy, where there is a special kind of a catheter which is passed. And through this catheter, this is a small device which causes fragmentation of the clot, and at the same time, those clots are sucked out through the catheter. Right. So this is how it is done. So it's a minimally invasive therapy, non-surgical technique without any thrombolysis. So it is generally quite safe. And this is how it is if the clots are sucked from the pulmonary circulation. This is the large number of clots which have been sucked and fragmented with catheter-directed thrombectomy to clear the clot from the pulmonary arteries. And this is the post-catheter-directed thrombectomy where significant perfusion was achieved. Now, the overall procedural success rates defined as hemodynamic stabilization, correction of hypoxemia, and survival to hospital discharge by percutaneous catheter-based therapies has been reported to be as high as 87%, but this technique is still evolving. So far, none of the studies have looked at mortality morbidity benefit with catheter-directed thrombectomy. However, this area does look promising, and we may be able to offer this option in future. The high PITHO study is awaited and may provide some much needed evidence. So take-home message, according to 2019 ESC guidelines for the management of acute pulmonary embolism, the systemic thrombolytic therapy is recommended for high-risk pulmonary embolism. This is the first-line therapy, the class 1B recommendation. Surgical pulmonary embolectomy is recommended for patients with high-risk pulmonary embolism in whom thrombolysis is contraindicated or has failed, and percutaneous catheter-directed treatment should be considered for patients with high-risk pulmonary embolism in whom thrombolysis is contraindicated or has failed. This is a grade 2A C recommendation. I hope you enjoyed this presentation. Thank you very much, and my best wishes to you. Thank you.